Thank you, Dirk, and thank you to PK for having me here again. We're looking at transportation and diffusion patterns. This is mainly about the transport Fempop disease. And it goes back to 1983, where we see Professor Tønnesen in Denmark showing his first results of popliteal axis. Interestingly, at that point, you want to go back?
I said they want to go back quickly,
absolutely.
and then you restart from the very beginning.
No, that's fine.
He's good? No. Okay, no, sorry.
All right. So anyway, at the time, it was mostly about bone marks and trying to locate with a Doppler needle. But then they actually developed the technique where they would get X-ray. And you just heard PK saying that he still uses this. So PK still uses this technique from 1983. Now, more advanced in the 94s, we were hearing about how we could dissect from above and below. Bolia showed a subintimal dissection would work from above, but then Heenan started saying how this subadventitial flossing could work from below. And interestingly enough, some of these dissections, as you could see, back from papers from the 90s showing complete resolution, something that we sometimes today attribute to drug-coated balloon technology, but it may just be normal. As it progresses through time in the 2000s early, we start talking about ultrasound axis, arterial flossing, having a through and through, and tibial axis, not only popliteal axis. And then more contemporary, we see Nishino and the Japanese starting to show us much more robust technical expertise, showing reduction of radiation by utilization of ultrasound, and certainly less complications with smaller sheets. And utilizing some of the techniques that in cardiology has helped for CTOs of coronaries, we have the cart and the reverse cart, where balloons are used from above and below to try to find the tract adequately, because you could be dissected from above and below and still not have adequate crossing. I put that all together if anybody's interested in a little paper back in the endovascular journal, Endo Today. So if you want to look for that, it looks at how the utilization of balloons can help you cross. Now, I'm not a cardiologist, I'm a vascular surgeon, so I just call it a balloon from above, a balloon from below, or maybe one or maybe two, or pull out an outback and get through. So there's multitude of ways that you could try to tackle these lesions. In our current practice, I can tell you that bidirectional technique is now a primary technique for any complex lesion. We don't diddle-daddle around with antegrade axis only and or above and below. As procedures become more efficient, less radiation and contrast are utilizing, leading to a safer overall intervention. And then the access site is now determined on the physician and patient comfort that leads to optimization of cath lab time. So flipping the patient over on its belly, accessing the pop, and then flipping the patient back has become a thing of the past. We try to get through cases fairly quickly. So I would say determine the complexity of the lesion and early adopt the retrograde axis for complex Fempop. Axis with microaxis, as Art was telling us, and certain O18 working horse, like a V18 control wire from Boston and or a Victory CTO wire, which will help you get through. Remove the needle and advanced microcatheters, sheathless if you may. You don't really need anything because you're just securing your retrograde axis to get through the lesion. Once you're flossed, meaning once you get a 300 or a 400 centimeter wire across from your groin axis down to your foot axis, you're done. You can do anything you want and you can lose your rail at the end of the procedure. Cart, reverse cart, or virtual true lumen, or whatever you choose to call it based on the specialty, is something essential that you need to feel very comfortable when you're working in two subadventitial spaces, and certainly treat as needed. When we're seeing this sort of disease pattern on a patient that had 3 failed bypasses, something that I deal with in Houston on a daily basis, since before we were there, endovascular therapy apparently had not come to Houston. Everybody would get 3, 4, or even 5 bypasses in their legs before they got anything. This patient, you could see 2 failed bypasses, one from the common, one from the SFA, and one from the profunda. Poor reconstitution of flow into a very diseased vessel, but you can see a perineal axis. I won't go into the details as a presentation next will be about perineal axis. But once we can get into that axis, we could actually dissect all the way and re-enter into the common femoral artery and now have a floss that will help us deliver therapy. In this particular case, balloon angioplasty, and you can see that the anastomosis and the clips are actually a problem when you're trying to do endo. So as opposed to a lot of people who say bad endo can lead to bad surgical outcomes, I actually flip it around and I say, you do a bad surgery, I'm going to have trouble doing good endo. Then you could put a scaffold, in this case like a interwoven superior scaffold, and certainly accomplish a very nice inline flow with a reconstitution of flow. But then we had to go and tackle the distal anterior tibial anastomosis, which was down, which we had to put then through this, a DES into the anterior tibial. But the most important thing is we got this foot to look like that, and eventually to look like that, and eventually to look like that. And this gentleman went on to walk and go about his life with the TMA nicely healed. This is the Division of Vascular Surgery at Baylor that we're leading, and we're always inviting anybody that wants to get involved and passionate involved in limb salvage and critical limb ischemia. Please give us a call. We have interns from all over the world come, and it would be a pleasure to have you with us. Thank you very much for the invite.